Well, now you're in for a treat. I'd like to introduce a physician leader who's been advancing the case for and the cause of population health for decades. As you'll hear, population health is his secret sauce. For us, it's the glue that increasingly is going to connect St. Luke's and our communities. It's part of our strategic framework. It's that important. It's also complex to implement, and it can be confusing to understand, which is why it's so important to talk about and why we have brought the leading expert in it here to talk to all of us today. Dr. David Nash is internationally recognized for his work in outcomes, management, medical staff development, and quality of care improvement. He is a tireless champion of improvement in outcomes and safety, a prodigious author and speaker, and a blogger, a man after my own heart, like that, and an outspoken advocate for the types of change that St. Luke's is pursuing. In your materials is his biographical information, so I'm not going to go through everything because we want to get right to his presentation. So if you would, help me welcome Dr. David Nash. Thanks. And if you need the pointer, use the green.
Great. Well, good morning. Thanks very much, David. It's easy to remember. David, that's easy. So it's really wonderful to be here. So I have never been to Idaho. So how awesome is this, right? To get to come to Boise. So for the last 22 years, 24 at Jefferson, I've been traveling back and forth across the country. My physician wife early yesterday said, "Are you going to a place you've never been?" I said, "Yes." She said, "Well, that's like amazing. There's a hospital you haven't been to?" I said, "Yes, there's a whole state I haven't been to." So it's really a thrill to be here. And later I'll tell you about our secret connection between David Pate and me. But I am thrilled to be here. Let me tell you a little bit about the genesis of today. So Courtney on your team, she and I started our long-distance romance on August 14th, 2013, to get to today. In fact, my wife was beginning to wonder, who is Courtney? Because of all the communication that we had. But seriously, I am thrilled to be able to come to St. Luke's. Let me give you the punchline. You're well on your way. In fact, I have a hard time thinking of a place that has really moved the ball down the population health field, if you would, as far as you have been able to do it. In other words, my British friends would say this is a little bit like bringing coals to Newcastle. In other words, the last thing Newcastle needs is more coal, but you get it. So my job today, I'm your setup guy. So I'm going to give you the big picture. I'm going to make it a lot easier for both your internal speakers and Mark later today. So you're going to have a wonderful day today and tomorrow. So my job is, how do we get in this jam? What's the big picture? Are you on the right road? And at the end, look around the corner and give you Nash's twisted view of where I think we're headed. So here's how we're going to do this, and I'm under no time pressure, which is wonderful. So we're going to do 4 things. Part 1, how do we get in this jam? Because we have an eclectic audience, and what David didn't specifically tell you, for all the board members in the room, in fact, if board members, would you raise your hand just to help me out here? Okay, great. Awesome. So, I feel your pain. So 10 years on the board, the corporate board for Catholic Healthcare Partners in Cincinnati, 5 states, 40,000 employees, 30 hospitals. So I did 6 trips a year from Philadelphia to Cincinnati times 10 years. That's 60 trips to help Catholic Healthcare Partners begin to grapple with some of the issues, of course, you're way ahead on now. And I'm currently on the board of, and I left that after a decade, and now I'm on the board of Mainline Health Systems, a 4-hospital community system just outside Philadelphia, where I chair the board quality of care committee. So board members, I get it. And I really do, I think, have a visceral appreciation for your hard work. And based on what I saw of where you're going, you have a lot more hard work coming your way too. So I really do appreciate that. So part one will be, how do we get in this jam and what is all this stuff anyway? Since we have an eclectic audience, I'm going to give some definitions and try to lay the groundwork for how did we get to February 2014. Part two, I've got to define population health because it's not clear what we all mean by population health. And since I'm the dean of the only school of population health, I, of course, have the right answer. Part three, we got to talk about health reform as it relates to improving the health of the population. And then finally, part four, I'm going to show you a picture of my family, and then I'm going to predict the future. So there's no future in predicting the future, but we're going to do it anyway. All right, for the internists in the room, here's the review. Part one, how do we get in this jam? Part two, what's population health? Part three, health reform. Part four, where are we going? Okay? Really important. Thank you. Finally, 1 or 2 minutes of shameless advertising so I don't forget. So since I came all the way to Boise, I expect many of you to come to Philadelphia in just a month from now, March 17, 18, and 19. Seriously, our brochure is out there. We're expecting over 500 persons. I have every national leader in our field, and I'm not exaggerating, will be at the Loews Hotel, downtown Philadelphia for 3 days in March. I really hope some of the leaders will be able to join us. Public and private, not-for-profit and for-profit, infamous and famous, will be with us for 3 days talking about their vision. The president of Humana, the commissioner of health for the state of New York, the CEOs of some of the largest not-for-profit systems and some of the largest for-profit systems will all be with us for 3 days. I really, really hope some of you will make the journey, and it'll be a lot of fun. Okay, so let's make sure the technology is working, and let's see. That's always a good sign. Okay, great. Well, once again, special thanks to Courtney. In fact, can we take a minute, a round of applause for the team that made it all possible? You know, it looks easy when you're all in a beautiful room like this on a lovely Friday morning, but believe me, I know how much hard work goes into this. Okay, a little bit of geography. So this is the floor of our gymnasium at Thomas Jefferson University. We are not in Virginia. We're in downtown Philadelphia. So Jefferson is one of our nation's 141 academic health centers. In other words, medical school, and a big hospital. And our place is unique. Of the 141 academic medical centers, 7 look like Jefferson, which is, this is the gymnasium, home of our undefeated basketball team. That's because we don't got one. So we don't have any pesky undergraduates, no law school, no business school. All we do, health is all we do. That's our tagline. So there's 6 schools, you can sort of figure it out, right? Jefferson Medical College, the largest private medical school in the United States of America. Nursing school, pharmacy school, allied health, graduate school of science, people silly enough to get a PhD in microbiology. And the School of Population Health, the school I am very privileged to lead, which is 4 years old. Much more about that later. And of course, our 610-bed university hospital. So that's Jefferson. More importantly, Philadelphia, birthplace of our country, you know that. 3 blocks from my office is America's first hospital, which is called what? America's first hospital. Anybody? Washington, Pennsylvania Hospital, of course, founded by? Now listen, any question about Philadelphia founded by, the answer is Benjamin Franklin, come on. So 3 blocks from my office is America's first hospital, right, of course. America's first medical school hospital, our arch rival, the Hospital of the University of Pennsylvania, there I said it. 20 blocks west of us. Home of the American College of Physicians, the National Board of Medical Examiners, the American Board of Internal Medicine, 4 of the nation's largest private medical schools. 1 out of 4 doctors passes through Philadelphia in the 21st century at some point in her training. Right? Because on average, America's medical schools are 52% female, a major social revolution, which is going to play out in Boise, Idaho. More on that later, too. So have I convinced you that Philadelphia is the center of American medicine and not that silly city on the banks of the Charles River? Okay, mission accomplished. Okay, so what David was really saying is this, right? You know, here's the BlackBerry. Raise your hand if you're still using one. Yeah, we got one or two. One or two. That's good. That's good. That's why he's retiring. He can't face an iPhone. Right. So I got a phone call 3 weeks ago at Jefferson. We have 1,500 university-supported web-enabled phones. 57 of us were left on a BlackBerry of the 1,500, and I was told I have to give it up. I had withdrawal symptoms, but I finally adapted to the iPhone. So I love this Bloomberg Business Week cover story because, you know, how the BlackBerry became a relic. It's exactly the same kind of thing of how Jefferson and St. Luke's could very rapidly become a relic if we don't adapt and adopt to the New World Order. And, you know, we always, as a society, overestimate change in the short term, and underestimate in the long term. And that is the risk, the balance, the tension that we'll be talking about throughout our time together today and in the question and answer. So I'd love this brand new cover story, how it became a relic. Just put a university hospital up there and we could really rapidly become a relic too. Okay, so whatever your politics here in the great state of Idaho, you know, I ain't interested. It's okay, whoever you vote for, no problem. But the tactical reality is, you know, we haven't felt the pain yet. No cardiologist has had a 15% decrease in his income yet. No orthopedist I know is unable to make a mortgage payment yet. So the pain level is not high enough yet to convince all of us that this is the right direction. But folks, here's a little bit of background. So our great country spends more on health care than any nation on the planet. You and I know that. And what do we get for the money we're spending? Everywhere but St. Luke's at Jefferson, what do we get? So we're number 17 in the world, just behind Slovenia, with regard to the quality of life of our society, based in no small part in the investment in healthcare. In other words, we're spending the most, and the value that we're getting for the money we're spending is quite questionable. We'll come back to that theme. So this is going to hurt. Yes, it will. And also, you know, I love this picture because, you know, he has a long, thin face. Look at the size of that syringe. And I can't tell whether the president is a surgeon in this picture, a pain therapist, but whatever it is, it's going to hurt for sure. But we haven't felt the pain quite yet. Sure, all the confusion about exchanges, that's not what I'm talking about. I'm talking about the real fundamental shift from episodic and acute care to improving the health of a population. And that's a big part of what today and tomorrow is all about. And of course, we'll come back to those themes. So nothing illustrates this transition better in my mind than this exact citation that I stumbled on in the research to one of our books a number of years ago. And you could read along with me. All integrated delivery systems like Jefferson and St. Luke's are accountable to the public for their degree of success. If this initiative isn't taken by everybody in this room, it will be taken by the lay public. This was a century ago, 1918, unbelievable. What's even more unbelievable, a bunch of surgeons wrote this. That's a joke, you understand that, yeah? So this is a direct citation from the inaugural meeting of the American College of Surgeons during the First World War at the famous Waldorf Astoria Hotel on Park Avenue, Midtown Manhattan, a century ago. So we're going to come back in the fourth part of our time together to connect the dots on transparency and public accountability, because a big part of being accountable for a population means total transparency on outcomes. We're going to hit those themes. So you should be thinking in the back of your mind about the themes of transparency and public accountability. And I'm a big proponent. If we don't do this, then we deserve the pain we'll feel under reform. In other words, it's up to us. As ridiculous as that is, it's totally up to us. And we'll come back, board members most especially. This is an important message. Okay, so some of the tactical realities, getting into part one together. So you have read all about this. Maybe you've not read the Physician Executive Journal, but we're moving from a world of volume, more is better. I have spent my whole professional life in two temples of technology, the University of Pennsylvania and Jefferson University. Two temples of technology built on the platform of what? More is better, more of everything. More parking spots, more caths, more open heart surgery, more endoscopy, more faculty, more drugs, more research, more students. More is growth, and growth is good. And now we're saying, wait a second, maybe that fundamental model for 30 years is broken. That's where we're at. And now maybe we have to move to a world of, well, volume's important, but we want to know the outcome of what we're getting for the money we're spending. Why is the United States at number 17 right behind Slovenia? This is a powerful social movement, not just a business issue for you and me. So this illustrates this move from volume to value. Here's another way of looking at it, but this is actually even more subtle. So we've been pretty good, and I know I have members of the quality improvement team here. We've been pretty good in measuring and improving what we do every day. Certainly our school has been at the forefront of aspects of this. My first book on quality is 20 years ago. So we've become experts at the checklist for performance. Did you order the hemoglobin A1C? Did you get the eye exam for the diabetic? Check the box performance measures, process measures in our technical language. Board members, you've seen all these process measures over the years. Now we're in a new world order of, well, all those processes are important, those core measures are important, but what are we, at the patient level, are the results better? Is the hemoglobin A1C improved over last year? Not the fact that you measured it, is it in the right direction? Now, you may think this is semantics. It ain't. This is a different way of looking at how we're delivering care and the outcomes of that care. So that's why Managed Care Magazine a year ago said, well, it's not just pay for performance, that's relatively straightforward. Now we want payment for results. And we'll come back to that theme as well. Okay, so this is a slide I stole from the CEO of Baycare in Tampa, Florida, because I thought it was so great. So here's a hapless intern, and he's sort of balancing on these two canoes. And the one canoe with this red REI backpack says, historical and current fee-for-service. And the other backpack, of course, is the one we're here talking about today, value-based performance and population-based care. And he's balancing between these two canoes so he could sail down the river in this canoe. What he doesn't know is 200 feet downstream is a 1,000-foot waterfall that he's going to fall off the canoe and perish. He could always just jump into the water and give up. Most physicians I know, 55 and over, when I'm done talking, come up to me and said, I just want to live another 4 or 5 years in the work world. Get me to that point, right? I get it. I get it. I'm sure you have a few of them in your system too. And then there's the righteous path and the other canoe sailing off to value-based, population-based care. And that's in part what the whole day today and tomorrow is all about. And I've simplified it, obviously, but now we could get into some of the details. Before we can get into what's population health and health reform, you're going to have to suffer a little bit with me. So here's a famous Business Week cover story, now called Bloomberg Business, but you get the idea. You could read the headline here. Medical guesswork from heart surgery to prostate care. They get that in there all the time. The medical industry knows little about what really works. What's this all about? Well, the doors are closed. We're among friends. There are no, outsiders here. So what's this about? Well, this is about what most doctors know, but difficult to admit. 18% of the time we have grade A evidence as to what the hell it is we're doing every day. 18% of the time, on a good day. In other words, 1 out of 5 clinical decisions at the bedside, in the operating room, in the office, we have solid science. The other 4 out of 5 decisions, what do you and I call that? We call that the art of medicine, right? I mean, that's okay. Far be it from me to condemn the art of medicine. A bolt of lightning will come down and strike me. But from a perspective of the employers who pay 52 cents of every dollar spent on healthcare in our country, that's how you end up with a magazine cover story which basically says, what am I buying? Can I get greater value? Can it be safer? These are the issues that large employers all across the country, even here in Boise, are asking. Can we achieve a greater value for the money we're spending? The absolute answer to that question is, of course we can. And I'm going to show you what it might take to be able to do that. So this is all about what we call unexplained clinical variation. For board members, that's probably worth writing down. The 3 words that describe the core of our current problem: unexplained clinical variation, which is a complex social system where doctors are taught these kinds of things early on. And in the question and answer, I want you to ask me more about unexplained clinical variation. That's the root of all evil in our system, and driving overutilization, poor outcomes, and it's not safe, just to name a few things. So the people who pay the bills, they're on to us, large employers and insurance companies. That's another part of our problem. I want to give you 2 references that if you have an opportunity to read, it'll really depress you. Here's the first one. This is called Mirror, Mirror on the Wall, June 2010, available online from the Commonwealth Fund in New York City. Details not important. Main message, we're not getting value for the money we're spending. Maybe in oncologic care, because our country spends more for the care of persons with cancer on a per capita basis than any other nation in the world, even by a higher margin than any other service. And the second report's got a really important name called Poorer Care. It goes like this. Sicker Care, Poorer Outcomes. And this is from the Institute of Medicine, January of 2013. So this is 2010, 2013. Message is the same. We're not getting value for the money that we're spending. And this is such a sad part of the underlying issue. So I want you to be thinking when we talk about reform, is the Affordable Care Act really designed to fix what's broken? That's not just a political question. It's an important strategic and tactical question with a complex answer. So will it fix this disparity? Will it really promote population-based care? We'll come back to that when we talk about population health. Main message for board members especially, we ain't getting value for the money we're spending. Okay. From a clinical perspective, and we're going back and forth here on purpose, from a clinical perspective, we have some other major challenges. Now, I know this doesn't happen at St. Luke's, but everywhere else, this is a huge issue, which goes like this. Classic work by Elizabeth McGlynn and her team at the RAND Corporation a decade ago, and follow-up papers in the New England Journal of Medicine, but here is the classic piece. When she examined what we actually do at the bedside, in the hospital, in the office, and so on, and compared that against the best available research evidence, in other words, these quality indicators, when based on hundreds of hospitals, thousands of patients, largely in California, now a decade ago, but subsequent papers have borne this out. If you believe the best research in our best journal, if you believe that, she says we get it right on average a little bit more than half the time. Now let that hang in the air for a moment. So before we can move to improving the health of the population, we have some blocking and tackling to do inside the hospital, inside the office, which would argue we have a lot of work to do before we can even take on economic risk, become a functioning ACO. More on that later. So part 1 is designed to deliberately make you uncomfortable that the platform, the foundation, whatever you'd like to call it, is shifting, has some cracking concrete, has a couple of loose nails. We have work to do still before we can achieve the vision of improving the health of the population. Elizabeth's work is one of several out there, of course. By the way, Elizabeth now is the Senior Vice President for Outcomes at a small outfit called Kaiser Permanente in California, where she's bringing this same mindset to their population engine that they've been working on since the Second World War. So we have a lot to learn about those kinds of delivery systems, and again, more on that later. Let me illustrate this for the non-clinicians in the room. So atrial fibrillation is a disordered heart rate, can be fatal. You need to be on blood thinners. It's a complex thing. Lots of elderly people get it. So when my late father was 80, he had atrial fibrillation like a lot of older, overweight men, probably idiosyncratic. He never really had coronary disease. Anyway, I put my cardiologist kid brother and my cardiologist uncle, my father's kid brother, in a room in Florida together. And I said, don't come out until you tell me how we're going to treat Dad. 6 hours later, they were still arguing. As just one example, just one. And we could go on, and all the doctors in the room know exactly what I'm talking about, because that's the art part of medicine. The challenge with the art is the people who pay the bills for what we do are not connoisseurs of great art. And in there lies a big part of our problem. More on that as well. Okay, so again, we're still pretty tactical. We have a lot of work to do still inside Jefferson and inside all of your delivery system, because for the first time in a peer-reviewed journal, way back in 1998, Don Berwick, one of the high priests of our movement. By the way, do you know that Dr. Berwick is running for governor of the People's Republic of Massachusetts? And he's soliciting campaign contributions. You know, 5 years ago, I could never get Don Berwick on the telephone. Now he's calling my cell phone on a regular basis. Oh, my God. Anyway, back in 1998, he said, it's possible to improve care and dramatically lower costs. 16 years ago, first time ever in a peer-reviewed journal, this happened to be Annals of Internal Medicine. So what was he thinking about? So I want to just hold this for a moment. So, you know, for doctors, this is a wait a minute moment. I don't get it. How can you improve care and lower costs? You get what you pay for? Well, no. That's really the core issue here, that one of the major ways we can improve what we do and lower costs is, of course, making care safer. So here's the Institute of Medicine list, right? This is the June 2011 report that stands behind the 1998 contention that Don had. The proof is in the research, and the research says the number one way to improve outcomes and lower costs is, of course, what? Reduce unexplained clinical variation and prevent harm. Board members, listen up. You're in charge of the quality and safety of care. Not David, not any single staff doctor, not the president of the medical staff, not your chief medical officer. The buck stops with you. If that doesn't make you have ants in your pants, I don't know what will. You're in charge of quality. You're in charge of safety. When someone's hurt, it's your fault. That's how you approach the quality and safety agenda. So I know you never have any inpatient errors at St. Luke's. I know you'd never harmed anybody. But this is your number one job. Number two job, now we can get into the details, you know, let's prevent avoidable hospital admissions. What exactly does that even mean? If we do that, we're going to hurt the bottom line right now, but maybe 3, 4, 5 years from now, that will be the new economic model. Oh boy, we're going to turn the battleship around inside the Panama Canal. That's really what we're trying to visualize here, right? Prevent avoidable readmission. Well, we're pretty good at that now. How come? Well, we got an economic incentive to do so. Your chief financial officer, he's going into the emergency room. He's looking for that decubitus ulcer. Excuse me, did you have that when you came in? Right? And it's okay to be readmitted as long as it's after those 30 days. Come on back, come on back. That's okay. So we're making some progress because we had an economic incentive to do so. What I'm arguing is way broader. What I'm arguing is it's your fiduciary responsibility as the board to ask the difficult questions about every single thing on this list. That's a hard job. Try doing it across 5 states in 35 hospitals. I would lay awake at night during my Catholic Healthcare Partners service, nervous. How could I possibly know what was going on in Paducah, Kentucky, right? So this is part of our world moving forward. Okay, now we can give a definition for quality. Here it is, 1991. Let's frame it up. So Brent James and others wrote this, the Institute of Medicine work, 1991. It's like ancient history. But it's got 3 surprisingly important and current core tenets. We'll go over them together. So the degree to which health services for individuals and the population, there it is, 1991, kind of a, harbinger of where we are today. Part 2, increase of the likelihood of a desired health outcome means we actually have to ask patients what's important to them. Holy mackerel. Do we get paid to do that today? Colleagues, do we get paid to ask patients what's important to them? Not on your life. I'm a poor primary care general internist, still seeing patients only in the office. I gave up my inpatient cleats 6 years ago when I became dean. So the core tactical reality is if I asked patients, excuse me, Mrs. Jones, 8 o'clock Monday morning, what's your desired health outcome? That would shoot the whole morning. So I ain't going to ask her. And I don't get paid to ask her anyway. I mean, I can say that and you're giggling, which I appreciate, but wait a minute. So in part 4, we're going to have to learn how to ask, what's your desired health outcome? And maybe, hopefully, get paid to do so. So part 1, population, that's important. Part 2, desired health outcome. Part 3, consistent with current professional knowledge. That's our secret code for we're going to practice based on the best available evidence. Not easy. We don't even know sometimes what the evidence is. In fact, we only have access to it typically 1 out of 3 times. We'll come back to it. So this is a tough definition. 1991, still the most available, most widely used. Okay. I'm assuming every board member's read this book. If you haven't, shame on you. 1999, Bill Clinton holds this book up in the press room of the White House. 1999 is ancient history, pre-9/11, an innocent era. Remember the peace dividend? Imagine that. So the president holds up this book and says, exact words, I commit my administration to reducing the epidemic of medical error. New England Journal of Medicine, 3 weeks ago, Yang et al. How we doing? D. That's our grade. C plus if you're an easy grader. D, 14 years later. Are you kidding? 15 years almost. So this is still pretty darn important. You ain't going to practice population-based care till you lick this. So that's why we got to go through the pain of this. Here's what the public sees, just so you think that they don't read this. Here's Marty Macary's book called Unaccountable Care that got a page 1 B-section review in the Wall Street Journal just about a year ago. How to Stop Hospitals from Killing Us. That's a kind of an upsetting story. Or how about this, my favorite Time magazine cover story of all time. What doctors hate about hospitals. Raise your hand. What's this story about? Anybody, help me out. This is the audience participation part. This is like my Oprah Winfrey act right here. Come on. Raise your hand. Anybody, what's this about? What doctors hate about hospitals. Front page Time magazine. What do you think? Board members, help me. Come on. You guys are super smart. Did you have not enough caffeine this morning? What's this about? It's an important moment. Say it again. Mistakes. Very good. You guys are super smart. What doctors hate about hospitals? Being a patient in one. That's what this is about. 8 physician families egregiously harmed from a preventable medical mistake, including Don Berwick's wife at Man's Best Hospital on the banks of the Charles River in Boston, when her 8 neurologists couldn't figure out what was wrong with her. Ordering different tests and different procedures, not talking to each other. Sound familiar? Right? So we got a lot of work to do. I don't want to be the soothsayer of doom and gloom, but we can't practice population-based care until we tackle some of this stuff too. Okay, good news. We know what works. We know what works. We've done a huge amount of work in the last 2 decades. Our school is one of 4 master's degrees in healthcare quality and safety in the country. I have 50 doctors from all over the country online with me at this moment from 26 states. learning the core tenets to get a Master of Science in Quality and Safety. Now, one school ain't going to fix this problem. 4 schools aren't going to fix it either. But the notion that in a partnership with the American College of Physician Executives and other stuff we'll talk about in the question and answer period, we are making progress. By the way, the number one way still in 2014 to improve quality and safety is wash your hands. My God, right? So I won't ask, David, what's your medical ICU hand washing rate? That's a number the board should have memorized, right? I mean, what could be more important than that? Something your mom taught you before you went to kindergarten. And yet at our place, we're super excited because our hand washing rate using secret shoppers and medical students doing direct observation with a hotline. Dr. Nash didn't wash his hands. We're getting there, 85, 87%. 4 years of gut-bustingly hard work. Okay? So again, blocking and tackling, pretty darn important. Okay, here's the other book every board member had to have read. Crossing the Quality Chasm, 2001. So to Errors Human, 1999, Crossing the Quality Chasm, 2001. What did this book do? The same people who wrote the Affordable Care Act in the basement of the old executive office building next to the White House wrote this book. That's the take-home message. And what'd they say? Well, there are 6 domains that describe care, and this is going to look super familiar to all of you because your plan looks to me to be largely based in part on the 6 domains, which is awesome. The first slide that David showed this morning to me resonated. Basically, those are the 6 domains baked into your strategy. So let's quickly review what they are, right? Care's got to be safe, number 1 priority. Will care ever be error-free? No. What's the goal? Care's got to be harm-free, right? It's never going to be error-free because we're dealing with people. Care's got to be harm-free. Care's got to be effective, patient-centered, timely. In Philadelphia, equitable is a super important issue. And, of course, efficient. These are not just, any kind of adjectives. This is a core component of what all care's got to be like, something our nation needs to strive for. Not in Boise, Idaho, but in Philadelphia, the issue of racial and ethnic differences in their access to care, how we treat people of color, huge problem nationwide. Not making light of it here, but clearly a big problem in the major population centers. So care that's effective means, hey, we got to base it based on good evidence. You can't do that test. That test doesn't make any sense. Or doing that test 4 times probably isn't smart, right? And the hospitals with portable MRI units parked in their driveway that doctors own probably don't make too much sense. We could go on. So my 85-year-old uncle was prescribed a simvastatin for his elevated cholesterol. So, you could argue this is 1-week-old information. I have family permission to tell this story, just to illustrate what we're talking about here. So my 85-year-old uncle lives in Florida, ground zero of Medicare overutilization, zip code 33437 if you want to know exactly. That's Boynton Beach, Florida. Don't go there for medical care. The sun is fun, the water's nice, the beach is great, but don't get health care there. So this 85-year-old uncle got placed on a statin for a borderline high cholesterol. We could argue primary prevention for an 85-year-old. What were they thinking? But okay. Then he got leg cramps, which is a known side effect. And without taking a really complex good history, the doctor then put him on narcotic analgesia for the calf pain he was suffering from the drug he probably didn't need in the first damn place. How about my 91-year-old father-in-law who goes to a mainline health hospital where I'm on the board for his annual visit and some knucklehead orders a PSA test on him? This is like Late Night with Conan O'Brien, right? Right? I mean, can you believe it? How about, okay, we'll do one more because there's got a couple of people still frowning in the front row. So my mother just had her 85th birthday on Valentine's Day. Is that the sweetest thing ever? Yeah. In calendar year 13, she had 3 CAT scans for her hiatal hernia. Now, board members, you should never have a single CAT scan for a hiatal hernia. She had 3. And of course, there's a core message in here. Why? Well, Dr. 1 ordered it because Mom had substernal chest pain and this squirrely thing, and she's had it for 40 years, but he didn't take a detailed history. And then she didn't like him that much, so she went to another doctor who she thought was way more handsome. He ordered a second CAT scan. Did he ever talk to the first doctor? No. Why should he? Why should the second doctor call the first doctor? Is there any compelling economic reason to do so? What's the answer? No. In fact, you could argue waste of time. By the third one, she went to a third doctor because an aunt of mine told Mom that he was really good. So, of course, there's a little bit of doctor shopping. That's what people do in Florida. They go to the doctor. It's part of the culture. But I'll close on this real story by asking you the question, who paid for those 3 CAT scans? Everybody? Audience participation, you all paid. That's exactly right. So, whoa, the 6 domains, super important.